Okay, everybody, so we're going to kick off because we have an audience online we've got 290 people online wondering why we haven't started, so we're going to respond to the pressure. So Bruce Harrell's my name, I'm the director of the Goodfellow unit, and we're partnered with the Australasian Society of HIV, Viral Hepatitis and Sexual Health Medicine to put on the seminar, which is about HIV PrEP update for primary care, acknowledging the fact that PrEP is now funded in New Zealand, so that's been a pretty amazing step. So now, because we have a live audience, I have to tell you where the fire escape is. You go down the stairs and out opposite the hospital building there. And I thought I'd also just tell you where the defibrillator is, because looking around the room, I'm the one probably most likely to need it. And I want you all to know where it is. It's just down at the bottom of the stairs to your left there. So should anything happen to me, run and get it. So I'm now just going to hand over to Dr. Nikki Perkins, who's a well-known sexual health physician in Auckland, to introduce tonight's speakers.
Thanks, Bruce. Welcome, everybody. There's a slight change to the program tonight because Vincent Cornelise is still on his way from the airport. So the first speaker tonight is actually going to be Dr. Massimo Giola, who's a sexual health physician and an infectious diseases physician based in Tauranga. He's going to be speaking to us about the issues and context of PrEP in New Zealand, the things you need to know all about it. Here he is. Welcome.
Thank you. Right, I'll start with my mihi. Kia ora tatou, ko Massimo Giola toku ingoa, no Tauranga ahau, kei Bay of Plenty DHB ahau e mahiana, tēnā koutou, tēnā koutou, tēnā koutou katoa. And someone will tell me when I'm 5 minutes before I'm supposed to finish. Yes, please. Fantastic. Good. So slight change of program, and we'll start with a New Zealand perspective first, and then Vince will tell us everything about the science of PrEP and all the clinical trials and all the scientific details. So in New Zealand, we start PrEP at a stage in the history of our HIV epidemic where the number of cases is going up, or was possibly going up until 2016, which was the year where we had the highest number ever of new HIV infections, and that was true also the year before and the year before. Apparently, from the preliminary numbers from the AIDS epidemiology group in Otago, the 2017 numbers are slightly lower. But we had 2 pregnant women diagnosed with HIV in New Zealand in 2017, so a bit of a trickle to the general heterosexual population. And we still had people dying of AIDS in New Zealand. So we had 8 AIDS diagnoses, 3 within 3 months of the diagnosis of HIV infection, so very late diagnosis, and 3 deaths. So these are the numbers by risk. So MSM represent the bulk of the New Zealand HIV epidemic, and they are the subgroup that keeps growing every year. Whereas for heterosexually acquired HIV, after Immigration New Zealand put a mandatory HIV test for granting visas, the numbers have been going down, but there are still heterosexually acquired HIV infections in New Zealand every year. As I said, the number of AIDS diagnoses is going down, but we still have some, and the number of deaths is going down, but last year we still had some. And we are starting PrEP in the context of very bad numbers for STIs. So we have, what is it, an outbreak? I would call it an epidemic, actually. I'm not sure if someone in Wellington is calling it an epidemic, but going from 50 to 450 in 2017, an increase of 5 times in 5 years, I would call that an epidemic, to be honest. And here, MSM represent the bulk of the new diagnosis of syphilis, but we are seeing increasingly a trickling of the syphilis epidemic to the general heterosexual population as well. So we had actually 2 cases of congenital syphilis in 2017 in the upper North Island, one in Rotorua and one in Whakatane. And as you will know, congenital syphilis is a major sentinel event. So the only acceptable number of congenital syphilis cases for a developed country like New Zealand is 0. Even 1 is a national scandal, and we had 2 in 2017. And gonorrhea, our numbers are going up, and the 2017 provisional rate is going up. I'm curious to hear from Vince, possibly later on during the discussion, what are actually the Australian rates of gonorrhea, but I suspect they are lower than this. And we don't know exactly how many of the gonorrhea cases are in MSM, because we don't have that epidemiological information yet. But as a surrogate marker, we know that the numbers of isolates of gonorrhea from anorectal and throat swabs in men are increasing. And we assume these anorectal and pharyngeal cases of gonorrhea in men are in men who have sex with men. So those are numbers. What about prevalence? We have some data that are getting older and older. So the Sentinel Sexual Health Clinics Prevalence Survey was now more than 10 years ago and showed a prevalence among gay and bisexual men attending sexual health clinics in New Zealand of 4.4%. And then we have the community prevalence study done by Peter in 2011, so 7 years old now, which showed a prevalence of 6% among gay and bisexual men in the community. The most recent data are from the Needle Exchange Program, 2013, and we don't have an epidemic of HIV among IV drug users in New Zealand. And we have to thank about that Richard Mitch, who was the only ID and sexual health physician in New Zealand before me, I'm told. So I'm kind of passing on his legacy, hopefully, because Richard was involved with the HIV epidemic from the early days, in the early 80s, and he was the one who really instigated and advocated for the needle exchange program among IV drug users that essentially avoided single-handedly an epidemic among IV drug users in New Zealand. And in 2013 was the last big survey among pregnant women, and we had 1 positive. And as I've told you before, in 2017 we had 2, which is a bit of a worry. Right, so PrEP comes as a natural sort of follow-up in my mind of PEP, post-exposure prophylaxis, which is not a new concept because we've been using post-exposure prophylaxis since the mid-80s for needle stick injuries in the healthcare setting. So really it's not a new concept to give someone antiretroviral medications to prevent acquisition of HIV. And in my mind, if you give it after exposure and someone is high risk, why would you not give it pre-exposure to prevent rather than try to patch up after the exposure has happened? We do have funded post-exposure prophylaxis for sexual exposures with special authority criteria. So the special authority criteria for that are 1 month when the exposure, when the source is known to be HIV positive and only for receptive anal intercourse, or for survivors of sexual assault. And in that case, it's basically at the discretion of the clinician to decide if the risk assessment indicates that prophylaxis is required. Now, the problem we have with that is that in the era of Grindr and the other dating apps, people don't know anymore even the true name of their casual sexual contacts. All they know is a name is a nickname on the app. So knowing for sure if your casual sexual contact is HIV positive is virtually impossible. So the special authority criteria are clearly out of sync with the current scenario where casual sex is happening in New Zealand. So I sort of enrolled the New Zealand AIDS Foundation in the new task of making a submission to Pharmac to amend the special authority criteria for non-occupational PrEP to become essentially the same as for the survivors of sexual assault. So basically, when the clinician considers that the source is high risk. We'll see. Paradoxically now, the special authority criteria for PrEP are more lenient than the special authority criteria for PEP. So someone could qualify for PrEP and not for PEP exactly with the same characteristics, which is obviously something to be amended. So 1st of March 2018, a month ago, PrEP becomes funded in New Zealand. What was happening before? Well, before, people were accessing PrEP via either the Auckland, New Zealand PrEP feasibility study in Auckland, based at the Auckland Sexual Health Center, that enrolled 140 participants, or self-funding and self-importing generic PrEP. We're not sure about the numbers. We reckon possibly there were a few hundred more people in New Zealand self-funding and self-importing generics. And now, from the 1st of March, Truvada, tenofovir DF, emtricitabine for PrEP is fully funded in New Zealand by Pharmac. The special authority application, the initial application, and the first prescription are to be done by a named specialist, and then repeats and follow-ups by GPs or other health practitioners. We heard from Pharmac at the National HIV Forum a few weeks ago that in the first 15 days, they received 150 first applications, not counting the 140 still in the Auckland study. So we're already looking at a few hundred people, and everyone who's a named specialist is getting referrals basically every week. So the numbers are quickly growing. So who are the named specialists? If you have a patient that meets the criteria for PrEP, how and who do you refer them to? So historically in New Zealand, the Ministry of Health has put together and maintained a list of named specialists that are allowed to prescribe antiretrovirals. It's not enough to be an infectious disease physician or a sexual health physician to be in the list. So you need to apply, even as an infectious disease physician or a sexual health physician, to be on the list. I've seen the most up-to-date list by the ministry, and it includes 45 names, but some of them are actually pediatricians looking after children with HIV, so they are not going to be involved with PrEP. Some of them are retired or do not work in New Zealand anymore. So going through the list and ticking off names, to the best of my knowledge, I ended up with 38. Of those 38, only 8 are sexual health physicians, and 10 out of 20 DHBs do not have any name in the list. Okay? It is highly unlikely that the ID physicians, who are not also sexual health physicians like myself, but all the other ID physicians, probably will not be very keen to be involved with PrEP. Certainly that's what we've heard from different quarters. So, and Auckland, to be honest, is the biggest concern, because after the very unfortunate job cuts that Auckland DHB made to the Auckland Sexual Health Center, we've lost 2 sexual health physicians in Auckland, and now we have 3 sexual health physicians working the equivalent of 2.1 FTEs for the whole greater Auckland region. So we're talking about 1/3 of the country in population size. Clearly, not Houston, but Wellington, we have a problem, okay? So how do you become a named specialist? The ministry also has a list of criteria. So you need competency, so appropriate specialist qualification in internal medicine, pediatrics, or sexual health, appropriate training, experience. You need to be current. I'm not going to read the whole list, just to tell you what are the main domains. And then you need to be credentialed, and you need to be reviewed every 5 years. And if you want to be in the list, you need to submit an application with all these criteria met, and the ministry has got a panel of 3 members that will decide, yep, this doctor is good to go and will be in the list or not. So the concept itself, I think it's quite reasonable, because historically New Zealand is a relatively small country with low endemicity and a very dispersed population. So what you want to avoid is to have like a solitary practitioner out in the whoop-whoops prescribing antiretroviral medications without really the training and currency and competency that you need to. So the concept, I think it's quite reasonable, but the process is really clumsy. So when I arrived in New Zealand in 2009, I came from a tertiary teaching hospital in northern Italy where we had 1,500 people living with HIV. I had personally under my care 300, and I was not allowed to prescribe antiretrovirals. So luckily someone was happy to say, yep, I think Massimo is good to prescribe antiretrovirals. So I was in the list reasonably quickly. But the process definitely needs some updating. So, one of the provocations I'm going to put there tonight is, could we have 2 lists? So one list for people living with HIV, where we want to have, only ID physicians and sexual health physicians with all the criteria met, and maybe one more inclusive for HIV prevention in the community, so including PEP and PrEP. That could be a reasonable, proposal to make to the ministry. And here I'm going to make another provocation, and this is really my personal opinion. It's not the opinion of ID Society or Sexual Health Society or anything else. It's my opinion. I don't believe being a GP you can be a specialist of everything, okay? So there will be GPs with an interest in HIV, and that's perfectly fine. I don't think all GPs really de facto can become antiretroviral prescribers. And coming here for a dinner and a CME event is very nice, and there are resources online you can go and read and so on. I'm a bit old style with that, so I think at some stage you need to have a bit of an assessment. Have you really learned what you were supposed to learn? So maybe we need, Joanne actually gave me the idea when she said, well, we have a national certificate in travel medicine. Why couldn't we have a national certificate in HIV prevention in the community? I think that's a fantastic idea. And it could be most online, and then maybe an assessment that could be online initially, and maybe a face-to-face weekend, 2 days, 1 day. We could sit down and maybe figure out something, as the Australians have the S100 program, really. So we can piggyback probably most of the Australian paperwork and stuff and just add the New Zealand specificity to it. So maybe it will not be too onerous to put together. Plus, I would strongly recommend, if you're a GP and you're thinking about prescribing PrEP, get together with some other GPs and perhaps a local specialist as well. Form a peer review group. Do not be isolated, because for the straightforward 20-year-old with no comorbidities, no concomitant medications, it will all be sweet and quick. But believe me, the tricky cases will come with older people, people with lots of comorbidities, concomitant medications, mental health, drug and alcohol issues. You don't want to be alone to deal with that. You want to have a small, but at least a sounding board of a local peer review group. That's my personal opinion. So how and where you refer? So at the beginning, on the 1st of March, they said, oh, why don't we just publish the names and the emails of the named specialists so the public can go straight to the specialist? And there was, of course, outrage and uproar. We can't manage that. So the referrals should be addressed really to the service, not to the individual specialist. And from what we hear, ID services are not going to be, are not going to accept by and large. I can be wrong, maybe some will, but from what we've heard, as a general rule, ID services will not be accepting referrals for PrEP. The sexual health services will, but the sexual health services might be overwhelmed very quickly with the number of referrals, so there might be a waiting list. And, what about virtual remote endorsement? I know some services are already doing it and find it a good way to deal. Personally, in Tauranga, I'm not doing virtual referrals, partly because our numbers are relatively small, but mostly because I do not really have any local GP I could trust in remotely endorsing, because I know they have no prior experience. Of course, in other towns like Auckland, Christchurch, Wellington, I'm sure the local sexual health physicians know who are the GPs that have got experience with PrEP, and they are happy to endorse. Still, it's a clinic. Like, I'm not going to endorse someone on the phone while I'm going to lunch, or after I go back home from work while I'm stroking my cat on the couch. I'm not going to do virtual referrals there. It takes time. It's a virtual clinic. So if you have 2.1 FTEs for the whole Auckland region, it's 2.1 FTEs. And the virtual referrals are to fit into those 2.1 FTEs. There's no escape from that. What are the criteria? So these are the criteria for the initial special authority application and prescription. So patient has tested HIV negative, is either male or transgender, and that includes trans women, and trans men. And patient has sex with men, is likely to have condom-less anal intercourse in the next 3 months, and has had at least one condom-less receptive anal intercourse in the last 3 months, or a diagnosis of rectal chlamydia, rectal gonorrhea, or syphilis, or has used methamphetamine. Or there's another separate scenario. The patient has a regular partner who's HIV positive, and the HIV positive partner is either not on treatment or on treatment but not undetectable, and condoms have not been consistently used. So essentially, the special authority criteria on one hand are recognizing the value of treatment as prevention and U equals U. So if your partner is HIV positive but undetectable, there's no need for PrEP. That's what the special authority criteria are saying. And as Pharmac made the decision to prioritize the high-risk men who have sex with men, they have included in the special authority criteria only the bottoms. Okay, so the exclusive tops, exclusively insertive MSM, do not meet the special authority criteria unless they have had an STI or used methamphetamine. Okay, the criteria might be widened. Pharmac said to us at the HIV forum they will review the special authority criteria in a year. So depending on how things go, they might review these criteria. And people who do not meet these criteria can still access self-funded and self-imported generic PrEP. So those criteria are based on reasonably good quality data. This is the Health in Men study in Australia that linked behaviors with the risk of contracting HIV. And you see how the exclusive tops have a much lower risk than the bottoms. Okay, so that's why the priority was given to the bottoms. And these are the criteria for the renewal. So basically, all of the ones we have seen before, plus the GP or whoever is doing the repeat prescription needs to give advice regarding risk reduction, needs to test the renal function, and do a full STI screening, including HIV, syphilis, and bacterial STIs, chlamydia and gonorrhea. And the applicant needs to have up-to-date knowledge about PrEP. Okay? So what else? There's quite a number of other things to know and do. So the special authority criteria are really minimum requirements. But if you want to prescribe PrEP so you need to do a few more other things. So So that's my own practice. Normally at baseline, I request a blood count, liver function, renal function, urines and urinary proteinuria, plus HIV, syphilis, and hepatitis, plus the multi-site chlamydia and gonorrhea screening. And if I find that someone is co-infected with hepatitis B, you need to make sure either you are competent yourself in treating HIV, HBV co-infection, or if not, you need to speak with a specialist who's competent about treating HIV, HBV infection. The reason for that is that the drugs in PrEP work also on hepatitis B, but hepatitis B is a bit of a vicious and nasty virus, doesn't like fluctuations in the viral load. So if you take someone with chronic hepatitis B and fully suppress the virus with PrEP, and then for whatever reason you stop PrEP, there will be a rebound of the HBV viral load, and sometimes that triggers an acute hepatitis that can even be a fulminant acute hepatitis. So basically, if people with HIV, HBV co-infection go on PrEP, ideally they should avoid stopping and starting, or if they stop PrEP for any reason, they must monitor their liver function very, very closely afterwards. And of course, if someone is not immune for hepatitis B, it's a fantastic opportunity to vaccinate them. Same thing for hepatitis A, and now for human papillomavirus with the Gardasil 9 vaccine. And then I review all the comorbidities, all the concomitant medications. The Liverpool HIV iChart app or the website are fantastic to check the drug-drug interaction. So if you're not familiar with them, you can download the app on your smartphone. You can have the website saved on your computer. Go and use it. It's great. And in some cases, older men, high risk for osteoporosis, I also ask for a DEXA. And that normally needs private funding depending on the different DHB agreements for that. So, as per special authority criteria, you need to check the renal function every 12 months. But really, this is a bare minimum. I would not recommend to do that only every 12 months. As per ASHM guidelines, the renal function needs to be tested at least 3 months after starting PrEP and 6 monthly afterwards. And if someone is very young or above the age of 40, or the baseline glomerular filtration rate, which is a marker of kidney function, is below 90, they need to be tested more frequently. And if this eGFR goes below 60, they should not be prescribed PrEP in the first place, or if they develop an eGFR less than 60 on PrEP, it should be stopped. So I've got a few anecdotes, a few cases we've come across. So I was doing my other jobs in Tauranga when I got a call from a rural GP saying, can you please endorse for me PrEP for this homosexual man in an open relationship who's sitting here in the office with me. With all due respect, when a GP uses that sort of terminology, a homosexual man in an open relationship sitting here with me, means they probably don't have a big experience in dealing with men who have sex with men. And in fact, when I asked, do you know anything about PrEP? He said, that's the first time ever I hear the word. So I said, okay, I don't think remote endorsement here is a good idea. Can you please send through a referral with all the details? And it turns out the patient is 65-year-old, smoker, type 2 diabetes on insulin, hypertensive, on 10 different medications. So I don't think I'll be comfortable in doing remote endorsement here. So I actually brought the patient to clinic. And I can tell you the rest of the story because between this time when I prepared the presentation and now, I have actually seen this guy. So the story is that he will be very happy to use condoms with casual partners, but the problem is that his own partner does not, his own regular partner does not accept to use condoms. And of course, the diabetes of our patient is wildly off, and he's got proteinuria at baseline. So I was like, I don't think PrEP is the best for you, but your partner is much younger and you tell me he's in perfectly good health and has got no comorbidities and no concomitant medications. So why don't you send your partner to me and probably he will be able to start PrEP and you will be protected because if he cannot get HIV, you will not get HIV from him. And if you use condoms with the casual partners, you'll be fine. So sometimes you have to think outside the box, really, something Italians are very good at. Actually, it's very hard to keep us in the box at all. So, yeah. A case I heard from Wellington, someone asking for PrEP. They have a severe skin condition on methotrexate. The dermatologist is adamant there is nothing else that works. They need to stay on methotrexate. When you go and check the interactions, the app and the website tell you you need to monitor renal function weekly if you're taking Truvada and methotrexate. I mean, who's going to do that? Who's going to organize that? Definitely not Wellington Sexual Health Clinic, which is busy enough as it is. Would the GP be prepared of doing weekly bloods? GPs do fairly frequent bloods for people on warfarin, for example, so the systems are definitely there. Is that an option? You know, how many GPs will be willing to put up their hands for that? Hopefully many. And then, of course, you know, another case from Hamilton Sexual Health Clinic. Someone goes to their GP and asks for PrEP. They do all the baseline and have a plan to refer for endorsement. And hoops, surprise, surprise, the HIV test comes back positive. So too late for PrEP. And it turns out that this guy was treated for syphilis a year before, but unfortunately, HIV test was not done at the time. So of course, you always need to remember STIs hunt in packs, and if you've got one, you are much more likely to have another one as well. So when you find someone who has got one STI, always check for all the others, including HIV. So these are the resources we have available so far. The ESHM PrEP guidelines and online course. I did a podcast, an audio podcast for the Goodfellow unit last year about MSM, sexual health in general. I was at the Goodfellow Symposium a couple of weeks ago, and Helen did an interview, so there will be a video podcast going up on their website soon, and we're doing this night today, and hopefully there will be more sort of events coming. So now I want to play a bit, as they say. Do you know where the Advocatus Diaboli comes from? Do I have a few more minutes? Yeah. So the Catholic Church, when they want to proclaim a saint, they have a process in a court, right? And there's one guy who plays the role of the devil's advocate, the Advocatus Diaboli, sitting there in a corner and trying to be the skeptical and cynical person saying, oh no, all these miracles you are talking about are all rubbish and there's a very good scientific explanation for them, and so on. So that's where the Advocatus Diaboli, the devil's advocate, comes from. So I'm going to play the devil's advocate now and say my personal concerns about PrEP, because now we are all in the enthusiastic stage and we think PrEP is the best thing since bread came sliced and everyone wants to be on PrEP and everyone is mad about PrEP. So I've got some concerns, and again, provocatively, and I hope there will be questions coming from the internet as well about this, I do have some concerns. And the first concern I have is about the equity of access. So the last thing I want is the Ponsonby Road Queens only being able to see their fancy GP in Ponsonby Road where they get their Botox and their testosterone injections and having their PrEP as well. So the last thing I want is for PrEP in New Zealand to be the thing of white, middle-aged, rich gay men, okay? What I want is the Maori 20-year-old from Kawerau to be able to access PrEP if it's indicated for them, okay? In Australia, they clearly had a problem with equity of access, and I was hoping Vince will tell us more about that. But when they did the big implementation studies in New South Wales and Victoria, they clearly struggled in having people in the study from non-English native speaker background, particularly Asian MSM, younger MSM, and not to mention indigenous Australians. So we definitely don't want to have the same issues here in New Zealand. So we need to start with the right foot here. Next, retaining MSM on PrEP is going to be a challenge. Yes, PrEP is funded, and as I see on the internet, on Facebook and so on, it's $5 for 3 months, fantastic. Yes, there are hidden costs though. So to get your 3 monthly repeat prescriptions, you need to see your GP, and we know that to see a GP, particularly in Auckland, particularly if you're not an enrolled patient, but a casual patient, it can be, you know, as much as $50, $90 a year. We are not a billing system like in Australia, so most people have actually to pay their GPs out of their own pockets. Very few people in New Zealand have a health insurance that includes GP coverage. So this is going to be a barrier to the access of PrEP, to the access to PrEP. And that's why we need actually multiple points of entry, and we need the sexual health clinics to be adequately resourced to provide free access to PrEP for people who cannot afford to see their GP. And we are definitely, as sexual health clinics, not in a situation now where we can do that. We can probably barely cope with the first applications, but definitely we cannot cope with the repeat prescriptions. And I hope my colleagues, sexual health physicians in the room, will tell us more about that. And then, of course, there are STIs. We know that people on PrEP are diagnosed with STIs more frequently, partly because we are testing people on PrEP more frequently, so we pick up more, but also because possibly there is a compensatory decrease in the use of condoms, okay? And as I told you at the beginning, we are starting PrEP in New Zealand during an outbreak of syphilis and with bad numbers of gonorrhea. So we are not starting in the best situation about STIs. And yes, we can treat STIs with antibiotics, but again, this is going to be a burden on GPs and sexual health clinics to deal with. And then we absolutely need to keep people on PrEP under close monitoring for HIV infection, because the last thing we want is for an outbreak of drug-resistant HIV to spread like wildfire among people on PrEP. And among the very few so far, luckily, but well-described cases of PrEP failure, 3 out of 4 involved multi-drug resistant HIV infection. Okay, so we definitely don't want to go there. And HIV has surprised us all so many times in the last 4 decades. First of all, with the existence of HIV itself. It was a completely unexpected epidemic coming out of Africa. And with its extraordinary ability to mutate and to adapt to new environments. So as I said above, the last thing we want is to have an outbreak of multi-drug resistant HIV spreading among PrEPers. And I know there is absolutely no evidence of that so far, but, you know, we need to keep that in mind and make sure people on PrEP are tested for HIV every single time they get a repeat prescription. And also, if someone on PrEP gets HIV, they could be treated with a suboptimal 2-drug regimen and therefore develop multi-drug resistant HIV on PrEP. Again, this is something we need to avoid at all costs. So it works, and to be honest, and I'll do my last provocation here, if PrEP becomes the individual owning my own sexual health thing for the gay generations from now to 50 years from now, I would think we have completely missed the point. So the point we want to make with PrEP is to stop HIV transmission in the next 5 to 10 years. So what we want, at least what I'm very passionate about with PrEP, is the public health outcome, not so much the individual health outcome. I totally appreciate people want to take PrEP for their own health, but as a country, we need to think about the public health outcome. So what we really need to do is to target PrEP to the very hot spots of the sexual health networks, the highly sexualized men who have sex with men, because if we stop them from acquiring HIV, they will stop transmitting HIV to the rest of the community. So the best outcome for PrEP will be if in 10 years we have stopped completely HIV transmission in New Zealand and we can actually ditch the special authority because we don't need it anymore. That will be the best outcome for PrEP, I will say. I will be, keen to see. And there are jurisdictions in the world that are getting there. This is 56 Dean Street in Soho, which is the biggest sexual health clinic in the UK. They have been aggressively implementing treatment as prevention and PrEP since late 2015. And while doing the same numbers of tests, in yellow, they have seen a sharp reduction in the number of new HIV infections. So when I saw that, I was like, that's nice. We want to see that in New Zealand as well. But if you go to the website of Public Health England and look for the numbers in the whole country, not just in Soho, London, you see that, yes, gay and bisexual male infections are going down in the UK, but this whole decline is driven only by London. So basically, if you live anywhere else in the UK, in England actually, if you live anywhere else in England, your risk of acquiring HIV is exactly the same, hasn't been impacted by the new biopharmacological prevention methods at all. So to me, that tells us that biopharmacological prevention works where the services are in place. And we need to ensure, again, I will repeat myself, that every kid in New Zealand living in rural East Cape or West Coast or anywhere in New Zealand, if they need PrEP, they need to have access to it. It's not acceptable it will be only an Auckland, Ponsonby Road thing. It needs to be accessible to everyone in the country. Okay, that's me.
Thanks, Massimo. I'm sure everyone has heaps of questions, but we're going to save them until after Vincent's presentation. So I'd like to introduce Vincent Cornelise. I think he's arrived, hasn't he? Oh, there he is. He is a sexual health physician working in Melbourne. He's going to talk to us about the kind of scientific, theoretical, academic aspects of PrEP. Welcome.
Sorry for being late, everyone. Sorry for missing your talk, Massimo. I always look forward to listening to your soothing, dulcet tones. While we're waiting for my slides to come up, there. I had a lovely taxi ride over from the airport just a few minutes ago. And Auckland, I've never been to Auckland before. It feels very familiar. It's very lovely and green. There did seem to be a bit of a language barrier with the taxi driver. So I think that's a New Zealand thing, maybe. Because he asked me, we got chatting, he was a lovely guy, and he asked me for my name. And I said, well, it's Vincent. And we'd already covered the fact that I was coming here and I was going to give a talk about PrEP, and I'd been educating him on PrEP. So there's at least one person in New Zealand who knows about PrEP. Because it's quite a long ride. And I said, so yeah, my name's Vincent, nice to meet you. And so he reaches over at the lights and he puts out his hand and he goes, well, it's lovely to meet you, Dr. Princess. I didn't have the heart to correct him, but so if you're catching a cab in the next few weeks and some taxi driver goes, I met this really weird doctor called Dr. Princess, that would be me. So anyway, I'm a sexual health physician in Melbourne. At the Melbourne Sexual Health Centre, and I'm also currently doing a PhD in sexual health epidemiology. So I've been involved in the Vic PrEP trial and the PrEP-X trial in Melbourne. I'm also work at Prayer Market Clinic, and at Prayer Market Clinic we've been doing PrEP since about 2014. So we've got a little bit of experience with it. These are my disclosures. And I came up with some learning objectives. So I was asked to talk about the science of PrEP, which I will do, but I think it'd be useful to give you just a kind of how-to guide for PrEP, just so that you can come away here tonight going, I'm going to do PrEP because I know how to do it. So we're going to talk about the effectiveness of PrEP, the risks of PrEP, talking about who PrEP is suitable for. I will talk about the authority criteria that you have here in New Zealand. But obviously, there are many more people outside of those criteria who could do with PrEP. We can talk about that. We'll talk about what to check when someone starts on PrEP and what to check for ongoing monitoring. And then if we've got time at the end of that, and hopefully we will, then we can talk about lots of tricky scenarios in PrEP, because there are a few. So I will kind of take it really back to basics so that, because there might be, I don't know everyone's background, there might be some people here who don't know very much about PrEP, and there might be people here who know a lot about PrEP. So to the people who know a lot about PrEP, my apologies, there is some stuff in here that's a bit basic. But PrEP is the daily use of a medication, currently tenofovir and emtricitabine, or Truvada. And I don't like using brand names, but I'm going to say Truvada in this talk, because saying tenofovir, disoproxil fumarate, and emtricitabine is a bit of a mouthful. And it's, so as I said, a daily use of that medication, so 1 pill a day on an ongoing basis to reduce the risk in someone who has an ongoing risk of HIV, which is compared to PEP or post-exposure prophylaxis. That obviously PEP occurs after a distinct risk event, and it's a reactive thing rather than a proactive thing, as in PEP is reactive and PrEP is proactive. It's very effective at reducing the risk of HIV, and we'll run through the effectiveness data. And as Massimo already touched on, it is not effective at preventing other sexually transmitted infections, except perhaps hepatitis B. But we should be vaccinating everyone against hepatitis B anyway. So who can have PrEP? So these are your special authority criteria. So in your special authority criteria, PrEP is mainly for men who have sex with men. There are some other categories. So there are transgender people who have sex with men. And there's another category of basically anyone who has a regular partner who's HIV positive, as long as that regular partner is not on treatment and has a detectable viral load. So that bottom group will be really small, because I would think that in New Zealand, like in Australia, most of the people who are living here with HIV will be on treatment and will have an undetectable viral load. So the chance of someone having a contact with his regular partner, blah, 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 is pretty unlikely. Transgender people, there will be transgender people who also need PrEP, and we will talk about that briefly, but most of the evidence for PrEP that we have to date is on men who have sex with men. And I will discuss it because it is an injustice that there haven't been more studies in transgender people. So let's talk about story. So this is a brief history of PrEP, and I'm going to focus on PrEP for men who have sex with men because of the eligibility criteria in your authority thingy. So this is where we are now, April 2018. PrEP is listed on Pharmac. Oh, that was March, wasn't it? Sorry, March 2018, PrEP was listed on Pharmac. If we go back in time, if we go to prehistoric times, so before PrEP came along, PEP, or post-exposure prophylaxis, has been available in the United States since about 1988, but that was for healthcare workers after a needle stick injury. In 2005, both the World Health Organization and the US Department of Health and Human Services guidelines recommended the use of PEP for sexual exposure, but if you read those guidelines, it's really mainly to do with sexual exposure in the event of a sexual assault. They seem to think that sexual exposure from consensual sex was somehow less deserving of PEP, but I don't know. So that's the background. But then so we had PEP, and as long as we've, I think, had PEP, there's been talk about, okay, so PEP is effective after exposure, but what if we bring that starting of PEP closer and closer to the event? Is it going to be more and more effective? And then someone, I can't remember who, someone came up with the idea of how about we get people to take it before a possible exposure event. So that's when the IPREX trial came in June, July 2007. Let's have a look at the IPREX trial. So IPREX stands for Iniciativa Prophylaxis Pre-Exposición. I don't speak Spanish, but it's okay. It ran in the USA, South America, Thailand, and South Africa, and they recruited 2,500 people, mainly men who have sex with men, but about 14% were transgender women. The median age of participants was 24. Sorry, am I standing in people's way, by the way? No? Okay. Stay. The study design was pretty simple. So it was a one-to-one randomization. Half of the participants went on to PrEP, and the other half got a placebo pill. And obviously no one knew what they were on. They didn't know, the participants didn't know, the clinicians didn't know. And then they just followed them over time and did regular testing. The median follow-up time was 1.2 years. They had a follow-up visit every 4 weeks, and at that visit, they had risk reduction counselling, so they had a discussion around condom use. They had adherence counselling, so they were asked to make sure that they were taking their pills. They did pill counts, and they dispensed the next 4 weeks of PrEP. And if someone came in with a symptomatic sexually transmitted infection, they'd also have that tested and treated for. And then every 24 weeks, or every 6 months, they'd have STI screening for asymptomatic STIs. So these are their results. They had 100 new HIV infections in their entire cohort, 36 in the Truvada group, and 64 in the placebo group. So if you put that together, that gives you 44% risk reduction, which is not great. But then they looked at, so they, like I said, they collected pill counts and self-reported adherence, which is all fairly good. But then when they looked at blood levels, they found that the people who seroconverted in the study who were on the Truvada arm, only 9% had detectable drug in their blood. So obviously most people weren't taking it. They did a post-hoc analysis after that, looking at only the people who had detectable Truvada in their blood and then compared them to placebo. And doing that, they found a 92% risk reduction. Then they did a pharmacokinetic modeling analysis where they worked out what blood level you would need to correspond to, say, having 3, 4, or 7 pills per week in your system. And they found that if you took 2 doses a week, you'd get a 76% risk reduction, 4 doses a week, 96%, and if you took 7 doses a week, which is obviously what we're aiming for, then you get a 99% HIV risk reduction. So that was IPREX. Now, let's scoot forward to PROUD. This is the end of 2012. So the PROUD trial was conducted in the United Kingdom, mainly in London, or I think only in London. PROUD stands for Pre-Exposure Option for Reducing HIV in the UK, an open label randomization to immediate or deferred daily Truvada or deferred daily Truvada for HIV negative gay men. Shows you how desperate we get when we try and come up with trial names. So just pick random letters out of sentences. So basically, it's an open label trial. So that's the big difference between PROUD and IPREX. IPREX was a randomized controlled trial, and no one knew what they were taking. In PROUD, people knew what they were taking. They were either taking PrEP or they were not taking PrEP, and they were just being observed. And then the guys in the observation arm would get PrEP 12 months after the start of the trial. 544 high-risk men who have sex with men, and if you look at their STI data, they really were high risk. Like the STI rates in this cohort were astronomical. One-to-one randomization with, as I said, an immediate start arm and a deferred arm, and they only did 3 monthly follow-up. So IPREX did 4 weekly follow-up. They only did 3 monthly because they figured, if we're going to roll this out into some sort of real-world scenario, there's no way we're going to monitor everyone for every 4 weeks. So let's do it in a way that's actually realistic. And these are their results. So overall, they have a 86% risk reduction, which is pretty good. Gives you a number needed to treat of 13, which if you compare to other medical interventions is a pretty great number needed to treat. But if you look at it's interesting if you look at the results in detail. So on the left, we've got the immediate start arm, and on the right, you've got the deferred group. And these are all their new HIV infections in either arm. Now, each horizontal bar is a new HIV infection. And the left-hand pointer end of the horizontal bar is the time of their last negative HIV test. The right-hand pointer of the horizontal bar is the time of their HIV diagnosis. So as you can see, there's 20 new HIV diagnoses in the deferred group. And if you look at the immediate group, there's 3 new HIV diagnoses. But if the top one was diagnosed within 4 weeks of starting the trial. So it's likely that he was already seroconverting when he entered the trial. So he likely acquired HIV before he started PrEP, I'm saying. The second one started and then had a HIV test over a year later, and apparently he never started PrEP. He picked up his supply and never took it. And the third one started PrEP, had a negative HIV test at about a year into the 12 weeks into the trial, and then obviously it was only given 3 months of PrEP, and then he was found in hospital seroconverting almost a year later, and obviously had run out of PrEP 9 months before. So with each of those, they really weren't on PrEP at the time of their HIV seroconversion. So you could, this is an intention to treat analysis. You're not supposed to take people out, but you could really argue that you could take those people out because they're not really PrEP failures. So that would take your, if you wanted to be optimistic, that could take your PrEP effectiveness up to 100%, but we're not supposed to do that. So that's IPREX and PROUD. Let's have a look at the IPIGAY trial in France, which started just before PROUD, but is a very different trial. Do you speak French?
I do.
Can you say that?
Intervention préventive de l'exposition au risque avec pour les gays.
Yeah, and I think avec is a really good word in that sentence, because this was a trial that was conducted with the gay community in France. And their question was, can we use PrEP in a different way? Can you take PrEP just at around the time that you're going to be exposed to HIV, which has been termed intermittent PrEP or on-demand PrEP or party PrEP by some people. So you know you're going to have sex, you know you might be at risk of HIV, so can you just take PrEP around that time? They got a bit over 400 guys in France who had a history of having anal sex without condoms, randomized 1-to-1 to either placebo or Truvada. Like I said, on-demand dosing, which I'll show in a sec, and their study visits were every 8 weeks. This is, it's a bit fuzzy because I think it's from my iPhone photo from the Corey conference, but this is their study design. So down the bottom, you've got days, and then the two smiley faces with a little love heart is symbolizing the act of copulation. The French are very romantic. It looks like little love heart, smiley faces. And that happens on Wednesday, according to this. And then if the IPIGAY protocol is at least 2 hours before sex, so 2 to 24 hours before sex, you take 2 PrEP pills, so double dose. And just to interrupt, but myself, there's been some pharmacokinetic modeling to show that if you take it 24 hours before sex, it's likely to be more effective than if you take it 2 hours before sex. So yeah, 2 to 24 hours before sex, you take a double dose, and then 24 hours later, you take one more dose, and 48 hours, you take another dose. That's around a single act of sex. Now, if you want to have sex again on Thursday, that's easy. You just keep going with the single dosing. So you keep going with the single dosing until you've come to act of sex. So even if these guys wanted to have sex again on Friday or sex with someone else on Friday, they would just take another 2 doses, if that makes sense. I think it does. So these are their results. They had 6 HIV infections. That's not right. 16? 16, thank you. Math's not very good. 16 HIV infections during follow-up. 2 of those occurred in the Truvada group, and 14 in the placebo group, giving a relative risk reduction of 86%. So this was a placebo-controlled trial. Now, I should have said with the IPREX trial, which was that first placebo-controlled trial we talked about, where they found that they had only 44% risk reduction and adherence was really low. Now, when those numbers came out, people were like, look, you see, guys can't take PrEP, they can't be adherent to it, this is never going to work. But I think it's important to think about, if you're a participant in a placebo-controlled trial and you know there's only a 50-50 chance that the pill that you're taking is actually going to do anything, your motivation for taking it would be pretty low. Like, you're not going to be able to change your sexual practices or actually rely on it in any meaningful way. And this is also reflected in IPIGAY. So they had in their randomized placebo-controlled trial, they had an 86% risk reduction. But then when they extended it to an open label extension so that people knew what they were taking, there was a 95% risk reduction. The main criticism of IPIGAY is that the average participant in IPIGAY took 15 pills per month. So they were having sex about 4 times a month or once a week. Now, 15 pills a month is, we know from the pharmacokinetic data from IPREX, is kind of the amount of pills that you need to take to get a pretty reasonable level of protection from PrEP. So the argument against the IPIGAY findings was, well, this just shows you that if you take 4 pills a week, you're going to be pretty safe from HIV. So they did a post hoc analysis looking at only the participants who took less than 15 pills a month, and those results are there. So amongst those participants, there were no seroconversions in the Truvada group, and there were 6 seroconversions in the placebo group. So I think, it's pretty reasonable data. And the new Australasian, which includes you guys, Australasian PrEP guidelines, which came out a few days ago, have an updated section on intermittent PrEP and give it as a possible option for people who don't want to take continuous PrEP. So that's just looking through these results, just summarizing. So IPREX, 44% overall, but 99% is fully adherent according to their pharmacokinetic modeling. IPIGAY, 95% in open label extension, and PROUD, 86% overall risk reduction, but all three seroconversions in the treatment arm were explainable. If, at this point, I was going to say, if my plane hadn't been delayed, there are some cases of known PrEP failure, and Massimo was going to talk about those, but he already has. You had that slide with the different, now, that's the trials. If you just want to have a quick look at the history of regulatory approval. So in mid-2012, the FDA approved the use of PrEP in the United States. In early April 2016, the Therapeutic Goods Administration in Australia approved PrEP. And now, as of April 1st, you guys beat us to it again, but as of April 1st, we've got PrEP on the PBS finally. So I just want to quickly have a chat about transgender people, because they are in your special authority criteria and they are an important risk group. So globally, there was a meta-analysis of HIV incidence in comparing transgender people to other special populations. And I can't remember the exact numbers, but I think there was something like a 45% odds ratio of odds ratio of about 45 of trans people getting HIV compared to the general population. Like, it's just a massive amount. That was a global analysis, and there are lots of biases in those studies because a lot of those studies are done on transgender people who do sex work. But anyway, the point is, it's an important risk group. IPREX did, as we saw before, include a small portion of transgender people or transgender women, but 340 of them. And unfortunately, in that group, PrEP was not effective. So they found 11 new HIV infections in the Truvada group and 10 new HIV infections in the placebo group. But the important point is that in none of the women who seroconverted, none of the trans women who seroconverted, did any of them have a detectable Truvada in their blood. They looked at the factors that affected adherence, and unfortunately, so when you look at this stuff with men who have sex with men, the guys who are at the highest risk of HIV tend to also be the most adherent to PrEP.
That's me, sorry.
Is that you? Okay. So among men who have sex with men, the guys who are most at risk of HIV are also the most adherent, which kind of makes sense. You know, people know that they're at risk. People know that if they go to a barebacking party, that they're going to be at risk of HIV, so they should be taking PrEP. Whereas guys who are kind of taking PrEP because they just want to be sure they have a sort of backup protection, they're not likely to be as adherent. Amongst trans women, that pattern didn't occur. So in transgender women, there was no correlation between risk and PrEP adherence. So a lot more work needs to be done looking at the barriers to adherence amongst transgender women. But their conclusion, this is from Madeline Deutsch, who runs, I think, the UCSF trans clinic. The conclusion of the paper was PrEP does seem to be effective if it's taken by trans women. And the new guidelines have a statement on trans and gender diverse people saying trans and gender diverse people have rarely been included in PrEP studies, and as a result, limited data are available for these individuals. Incorrect assumptions can be made about trans people and their sexual practices, although they may practice vaginal or neovaginal and anal intercourse or insertive and receptive sex. So trans people and gender diverse people who are at high risk of acquiring HIV on the basis of their sexual history are eligible to access PrEP. It's not rocket science. So that's the effectiveness section. Did anyone have any questions on that? How are we going for time, Katie?
We're good.
We're good?
We're going to save questions till the end.
Okay.
Because we're fielding them from the...
So moving on. What are the possible risks of PrEP? So there's a few, but they're not really massive. So there's potential renal toxicity. Are all of you coming to the HIV update tomorrow? No, not everyone? Because I'm talking about, tomorrow at the HIV update, I'm talking about renal toxicity and bone density loss in PrEP users, particularly focusing on older people who may need to go on PrEP or may want to go on PrEP. But just to mention briefly, there is some risk of renal toxicity. It's mainly limited to either people who are over the age of 40 or 40 or 50. So mainly occurring amongst people over the age of 50, but also some increased risk among people over the age of 40. And that's all you need to know. No. So it is recommended that people have a renal function test before they start PrEP, and then on an ongoing basis every 3 months at least, whilst on PrEP, to make sure that there's no kidney toxicity. And the toxicity comes from the tenofovir itself. So tenofovir is potentially toxic to the proximal renal tubules. That's all I'll say about renal toxicity. There is also a possibility of some bone density loss. So tenofovir does affect the osteoblasts and osteoclasts in your bone. And in the IPREX trial, there was about a 1.5% to 2% loss of bone density amongst PrEP users, which sort of maximized at 6 months of PrEP use. It didn't progress beyond that, and when people stopped their PrEP, it recovered within 12 months. So there's no guidelines, none of the guidelines suggest bone density monitoring or screening at the start of PrEP use. So you don't need to come tomorrow anymore. It's all covered. The things I do want to talk about are the risk of resistance to antiretroviral medication, which Massimo already briefly mentioned, and the risk of a hepatitis B flare if someone has hepatitis B and they started on PrEP. So the IPREX trial looked at antiretroviral resistance at enrollment. In that trial, 2 participants had unrecognized HIV infection at enrollment. So they had a HIV test. It was negative, but they were already seroconverted. They mainly used rapid tests in IPREX, so there's obviously a little bit of a longer window period in the rapid test, which we've subsequently seen in meta-analyses as well. So 2 participants had unrecognized HIV infection at the date of their enrollment, and they were randomized to Truvada. Both of those subsequently were found to have an M184V or M184I mutation. So that's a mutation that confers resistance to emtricitabine, which is one of the components in Truvada. One of those participants, they found when they went back to look at the blood that was taken at the start of the trial, they found that before that person started PrEP, they had wild-type HIV. So showing that the mutation that they found subsequently was an induced mutation as a result of taking PrEP. It was good to see there were no tenofovir mutations. So tenofovir was fully effective in all of them. And tenofovir is arguably the most important component of the PrEP pill. And this is looking at antiretroviral mutations during the study. So 48 participants in the Truvada arm in IPREX were diagnosed with HIV during the study. Of those, only 8 had detectable drug levels either at their diagnosis visit or in the 90 days preceding the diagnosis. So there were only 8 who were properly taking PrEP, or at least taking PrEP in some form or another. And in those, no mutations were detected on standard genotyping. When they then went back and did some fancy-smancy ultra-sensitive genotyping, they found that 2 participants had a minor variant of M184I, but it was really minor, so their conclusion in the paper was there are no clinically significant mutations that occurred in people who seroconverted during PrEP. PROUD also had a look at antiretroviral resistance. They had 2 participants in the immediate start arm who had HIV at their enrollment visit, but it wasn't detected at enrollment. And 1 participant in the immediate start arm tested positive at 4 weeks. Out of these 3 participants, 2 of them had an M184I mutation, so again conferring resistance to emtricitabine, and no one had a tenofovir mutation. Then, so that was their baseline data. When they looked at participants who got infected during the study, 2 participants got infected in the immediate start arm, and neither of them had mutations, but also neither of them had been taking PrEP. So their conclusion was antiretroviral resistance is mainly a problem if PrEP is started during seroconversion. It doesn't seem to be a significant problem if someone seroconverts during PrEP use. And I guess you can kind of think and speculate about this logically, that if someone's going to seroconvert during PrEP use, they're probably not taking PrEP. Because if they were taking PrEP, they wouldn't be seroconverting. There are those 4 cases where a couple of people got a multi-drug resistant HIV, which Massimo talked about, where they got HIV from someone who was carrying resistance mutations, and hence their PrEP didn't work. So that's the resistance. Hepatitis B, there's only one slide, I think, on hepatitis B. PrEP contains tenofovir. Tenofovir is an antiviral that's also effective against hepatitis B. So the worry is that if you have someone who has hepatitis B and you suppress their hepatitis B virus with tenofovir during PrEP, and then subsequently they stop their PrEP, then you can get a flare of their hepatitis B when they stop their PrEP, which can result in significant liver toxicity, liver damage. So the moral of the story there is make sure you do hepatitis B serology on participants when they start PrEP. And you should anyway, because these are people who are at risk of hepatitis B virus, so you need to know if they're immune to hepatitis B so that you can immunize them. But also if someone has hepatitis B virus at the start, then that should probably be discussed with the hepatologist. What we tend to do in the clinic, because it really doesn't mean that they can't start PrEP, they just can't stop PrEP. So it kind of sounds a bit, but you know, they should probably be on tenofovir anyway, because it's not great to have lots of hepatitis B virus bombarding your liver. So most of these people that we've come across in the clinic that had hepatitis B have started PrEP, and they've done fine. I've also seen quite a few people who have hepatitis B who are on tenofovir or entecavir for hepatitis B treatment and wanted to start PrEP, and we've just switched them over to PrEP. That's been fine as well. Oh, so sorry, there was another slide. So PrEP and hepatitis B. In IPREX, there were 12 cases of chronic hepatitis B, and 6 of them were randomized. They had really good randomization. Everything was randomized equally. 6 of them were randomized to Truvada, and they found no hepatitis B flares even after the Truvada was stopped. They did have 4 cases of acute hepatitis B, and 2 of those were randomized to Truvada. Out of those 2, 1 developed hepatitis B immunity, so the hepatitis B surface antibody came up, and the other one lost their hepatitis B surface antigen, but that person left the study before they could develop immunity. And there was no resistance to either tenofovir or emtricitabine in any of those hepatitis B genotypes. So it looks like it's safe. Now, I'm going to give you a quick, you've got the thingies, these beautiful how-to guides that Ashim produced last week. So this part of the talk is just a sort of a how-to guide on how to do PrEP. And I thought you've all got a copy of these, so we might as well use that to guide the discussion. So the first bit is the eligibility, number 1. So it's assessing whether someone needs PrEP. Now, I think you need to sort of conceptualize this in 2 different ways. There's 2 types of scenarios. There's either someone sitting in front of you who you think might have a risk for HIV. So maybe you're seeing someone who's got anal chlamydia or syphilis, or they're struggling with their methamphetamine use, or they're drinking a lot, or they're going to lots of sex parties. So anyway, someone that you kind of go, oh, I think that person's at risk. And that's very different from the scenario where someone comes to your clinic and says, I want to start PrEP. And I think it's important to sort of distinguish those 2. So I think the eligibility criteria are really useful when you're assessing someone who you're not sure if they need to start PrEP or not, and then, as long as you've got the eligibility criteria in your head, you can make a risk assessment. I think if someone comes to you asking for PrEP, you can certainly, if they want to talk about it, you can talk about the eligibility criteria and what puts someone at risk of HIV. But we've done a few analyses of the eligibility criteria in PrEP-X, which are in press at the moment. They were presented at EACS, at the European AIDS Conference. But we showed that, so in PrEP-X, in the large PrEP trial in Victoria, where we had about 3,000 people on PrEP, we used basically the ASHM eligibility criteria, but we also had an exemption clause. So if someone didn't meet any of those eligibility criteria, they could still be enrolled onto the trial if their clinician felt that that person would benefit from being on PrEP. And that benefit for being on PrEP can be anything, and they sort of freehand coded that. The point of this rambling story is that the people who didn't meet the eligibility criteria, who came into the clinic asking for PrEP, even though they didn't meet any of the eligibility criteria, still had a significant HIV risk. So they had quite a substantial amount of anal chlamydia, anal gonorrhea, and syphilis at their enrollment visit. And we also did a comparison looking at why people were enrolled, under which eligibility criteria they were enrolled. And then we compared that to what those people reported on an anonymous iPad, which asked similar questions. And what we found in that analysis was that people underreported condomless anal sex with casual partners, and people underreported methamphetamine use to their enrolling clinician. as in people may not be willing to tell you what their risk is. So if someone comes to you asking for PrEP, they probably are at risk of HIV and they probably should go on PrEP. That's my soapbox moment, so there you go. That's not in the guidelines. So you can either assess them. So there's the eligibility criteria here on the back of your sheet. So the risk criteria for men who have sex with men are on your left. We won't run through all of them, but it's just, it's condomless anal sex with casual partners, methamphetamine use, previous STIs. And then it's classified as either high risk or medium risk. So if someone's high risk or medium risk, then you proceed to step 2. If someone's not high risk or medium risk, then please keep in mind what I just rambled to you about eligibility criteria, because they may still be at risk and they may still need PrEP. Let's have a look at step 2. So this is the clinical assessment of someone who you want to start on PrEP. The first bit, it looks a bit complicated, but it's really not. The first bit is making sure they don't have HIV. Sounds simple, so do a HIV test. They've either had a negative HIV test in the last 7 days or you're doing a HIV test today. But there's a couple of caveats. You just need to check whether they may have had a significant HIV exposure in the last 72 hours, because if they've had a significant exposure in the last 72 hours, then they really we should have a different chat with them. It's the PEP chat, which is not much different, PEP and PrEP, except in PEP there is a provision for 3-drug PEP in someone who's had a really high risk exposure, and the follow-up is a little bit different as well. So just keep that in mind. And obviously, if the other caveat is that if someone's had a high risk exposure in the last, say, 6 weeks or so, you may not be able to clear that exposure by doing a test today. That doesn't mean they can't start PrEP, but it means you might need to follow them up a bit more closely. So you might need to do another test, say, 4 weeks after you start them, just to make sure that they definitely are in the clear from a HIV exposure point of view. Does that make sense?
Mm-hmm.
Yeah? Sorry, sometimes I think my mouth just keeps rambling and I don't know if it makes any sense what's coming out. The other bit that you need to check is their kidney function, which we talked about before. They need to have an eGFR of greater than 60. And then just check if they're taking any nephrotoxic medications, particularly non-steroidals. Having said that, in none of the trials have non-steroidal use been shown to be associated with kidney problems in PrEP. But then I think it's fair to say that, because most participants in these PrEP trials are really young, so the likelihood that any of them were taking non-steroidals on a regular basis is pretty low. So I wouldn't use that as a way to say that non-steroidals are fine. Taking a couple of Nurophens for your headache on Sunday morning is fine, but people being on non-steroidals every single day whilst on PrEP, I think, is probably not a good thing. But like I said, that hasn't borne out in clinical trials with those caveats. Other testing, this is important, and this is what Massimo talked about before as well. So STI testing is really important. We do see a large amount of STIs in PrEP users. There was a meta-analysis by, I think it was Jeff Klausner last year or the year before last, showing that looking at all the PrEP trials and comparing men who have sex with men in PrEP trials versus men who have sex with men not on PrEP trials, and they had an odds ratio of syphilis of like 40 or something, or chlamydia 15 and gonorrhea 24 or thereabouts. So it's really important that you test for STIs at baseline and then ongoingly every 3 months. Like I mentioned, you need to, I was going to go here next. So this is the Australian STI management guidelines. I don't know if you've seen these, but they've been updated in the last couple of months as well. And if you want to know what tests to do for a gay guy who wants to start PrEP or is on PrEP, have a look at the populations tab. So if you Google Australian, well, it should be Australasian, but Australian STI management guidelines, this will come up. If you click on populations and situations, and then there's a section on men who have sex with men. And I won't go through all of it, but it basically lists all the STI checks you should do. I'll just highlight this, that anal and throat STIs are particularly under-tested and unrecognised amongst men who have sex with men. They're usually not symptomatic. And it's not uncommon that I see a young gay guy who's been to a GP somewhere for a full STI screen and just got a urine test done. And people just don't seem to think about the anal swab and the throat swab for gonorrhea. And the anal swab also for chlamydia, but yeah. And then do a hepatitis C test. We now have great cures for hepatitis C. So we're only going to cure the world of hepatitis C if we do lots of tests. There is some suggestion that hepatitis C can be sexually transmitted amongst, this has particularly been seen, it originally was seen mainly amongst people who are living with HIV, but we're now starting to see the same thing amongst PrEP users. And originally it was said, oh, this is high-risk sex, so it was fisting parties and, well, I think that's the only thing that comes to mind right now. But I've made a few diagnoses of Hep C and PrEP users who swore they weren't going to fisting parties, which, I don't know. The reason I'm laughing is because I can hear myself talking and go, why would they tell me they were going to a fisting party? But I did ask them. That's all I can say. Whether everyone tells me the truth, I like to think people tell me the truth, but whatever. So this red box here is the baseline testing to do. This is again on the flip side of your card, nice and easy. And then the other thing on the back of the card is the patient education. So this is the stuff to talk about when someone is starting on PrEP. So talk about what is their HIV risk and how may they modify their HIV risk in addition to being on PrEP. And talk about their risk of STIs and that sort of thing. Talk about the role of condoms. Mention perhaps that PrEP is not quite 100% effective, and that obviously that adherence is really important to maximise effectiveness. Check mental health and recreational drug use. The gay and bisexual men in Melbourne, and I presume it's the same here, are disproportionately affected by adverse mental health conditions and by recreational drug use. Particularly, we're seeing a lot of crystal meth in Melbourne, which I'm sure you've probably seen the same thing here. So I think this is a great opportunity to talk to people about this and check in with them, see if they're going okay and see if they would like any help. Talk about adherence, I said that. You need to mention, and this is a bit of a schism, mental schism, for daily PrEP, so taking PrEP every day, it's recommended that people are on PrEP for 7 days before they rely on it to be effective. And they need to continue for 28 days after their last risk exposure. Now that 28 days bit comes from the PEP guidelines. No one's actually ever done a trial on how long do you need to be on either PEP or PrEP after an exposure, because you can't do a trial on it. The 7 days comes from the pharmacokinetic modelling from IPREX, but obviously, I don't need to tell you this because I'm sure you figured this out as well, that doesn't match with the IPAGAY model of dosing. We've talked about this ad nauseum during the guidelines, well, what are we going to do with this? And in the end, we decided not to do anything with it because of that. So there you go. So just, if they're going on daily PrEP, they're advised to be on it for 7 days before their risk exposure. And ongoing monitoring every 3 months, and talk about medications, including over-the-counter medications and herbals that may affect kidney function. So then you go to prescribing PrEP, number 4, and as we've talked about, you either do daily PrEP or on-demand PrEP, which this on-demand bit is new in the, as I said, in the Australasian PrEP guidelines. Important point to note that on-demand PrEP is only to be considered as an alternative regimen for men who have sex with men. There's not enough evidence for on-demand PrEP for women or for transgender people. Now, I'm a bit uncomfortable with that last statement because transgender people is sort of lumping lots of people together who do have different acts of sex with different risks. Certainly, if you're talking to a trans woman or a trans guy who mainly practices anal sex, receptive anal sex, the bottom, then I think it's fair to say that you can extrapolate the MSM data to that person. Because in the end, it's about the act of sex, it's not about the gender identity of that person. But that would be sort of a detailed one-on-one discussion with that patient. Or, sorry, PrEP user, I think is the correct term now. And then ongoing monitoring. So again, on the flip side, there's a thing on ongoing monitoring here. On what you check every either 30 days after initiation, and that 30 days after initiation, like I said, is particularly important if someone's had a recent HIV exposure, or if someone has some added risk, like renal risk factors, for example, so if someone's a bit older. So if they're over 40 or over 50, then maybe you want to get them back at 30 days to do another kidney function test. But other than that, every 90 days, do a checkup. And we're not doing questions. And that's it. So I just had some tricky scenarios that we can talk about if we've got time for. And it's nice to meet you, Nikki.
Nice to meet you. We're actually on time now for questions. We've got half an hour though, so we could probably cover some of the tricky scenarios.
Oh, fantastic.
during that time.
I didn't go over time.
Eh?
I didn't go over time.
No.
It's like
no,
the first time ever.
Yeah.
Um,
So maybe, where's Bruce? Would you like both speakers up there for taking questions? Yeah, and we're going to have questions from the floor, and there's questions coming from the webinar.
Thank you. I'm good. How are you?
Actually, I'm just going to sneakily say a couple of things here. The New Zealand AIDS Foundation, just speaking about GPs who have an interest in PrEP prescribing, the New Zealand AIDS Foundation have a list of PrEP prescribing GPs, which was originally when people were having to import their own PrEP. So they've got a list on their website. If you want to be on the list as a GP who's interested in prescribing PrEP, so that people can then have a look, see that you're interested, go see you if they want to start PrEP, please get in touch with the AIDS Foundation team at the back of the room. And there's an online email for them too, info@nzaf.org.au. And the second thing I wanted to say is just a reminder that we do have our own New Zealand sexual health guidelines as well, which many of you will be aware of, in terms of
That's why they're not Australian.
those Australians, God. And it does have a section on what tests to do for men who are having sex with men. Those are available on the New Zealand Sexual Health Society website. Thank you.
I should have asked that.
So what's the plan for questions? Do you want to take questions from the floor first? I've got the mic and I'll bring it round if you just put your hands up. Edward Coughlin from Christchurch.
Yes, it was just a quick question about the renal function test. You've got that urine albumin creatinine ratio there, which I know,
It's supposed to be
which
protein creatinine ratio.
as opposed to the maybe a protein creatinine ratio.
How did we miss
Pick.
Apologies to everyone. Yes, protein creatinine ratio, because we're looking for renal tubular toxicity, not glomerular toxicity. Yes.
Oh, sorry.
So, Katie, can we go back to the printers?
Short question.
Heather Young, Christchurch. I had a question for Massimo or both of you. We have it where they have a nurse appointment first and they do all their STI testing and bloods and go through the tenofovir leaflet and the antiretroviral syndrome and side effects and eligibility criteria, and then they're booked for a doctor appointment with the results of the STI screens and the bloods, and we get the special authority criteria. It's often there's a week later usually, and I notice a lot of them, even though they've been given the information beforehand, a lot of them have had sex, unprotected sex, in that week beforehand. And I look here and it says start in PEP, but I haven't been doing that because it's usually an unknown source, and we can only get funded in PEP for a known source, and otherwise in Christchurch we do Reltigravir in Truvada and they'd have to pay and it's really expensive. So I just think if I wait another couple of weeks the same thing's going to happen. So I've been starting with great trepidation people on PrEP, thinking should I bring you back much sooner than your 3-month appointment to make sure you're not seroconverting when I'm putting you on it.
Yeah, I would probably bring back such a person after 4 weeks to repeat an HIV test.
So so I don't know what your PEP guidelines are, obviously, my ignorance. But in Melbourne, the PEP guidelines, if someone's an unknown source, then the PEP guidelines recommend two-drug PEP. So that would be Truvada anyway. And we're currently sort of umming and ahhing about the same question because now PrEP is on the PBS as of a few days ago in Australia. It is just much easier to get those people onto PrEP. But just as I mentioned, have a different follow-up for them, to follow them up sooner. And obviously if someone has a known source exposure, but then you're really talking about a known source who's not on treatment and has a detectable viral load, because if someone's on treatment and is undetectable, then it's a non-issue anyway. But if it's a known source exposure, then we would recommend 3-drug PrEP, which I guess fits in with your guidelines,
Yeah.
and that someone would then be eligible for PrEP.
Yeah, for us, it's not a problem of guidelines, it's a problem of funding criteria. So the funding criteria for PEP and PrEP are currently out of sync in New Zealand, because for PEP you need to have a known HIV positive source to be funded, which you never have.
But fortunately now you can just use PrEP for all those guys who don't have a known source, who in Australia would be treated with 2 drugs anyway. So you can, I guess all I'm saying is you can rest easy. You don't need to lie awake at night worrying about what you're doing for your recent contacts.
Just a question about the IPREX trial and the 99% risk reduction after 7 days. Was that with or without condom use, or was that not?
So in IPREX, guys were counselled to use condoms, but that's both for the guys in the placebo group and the guys in the treatment group. So they're both, you'd think they both, and no one knew what they were on, whether they're on placebo or on PrEP. So you would think that there was similar amounts of condom use in both groups, and with that there was a 99% reduction in HIV incidence in the treatment group.
Right. Were there any figures for 100% condom users, so low-risk groups, who are asking for PrEP?
No. Because they haven't really been studied. So no one's done a study on PrEP for people who have no HIV risk.
They start with no risk.
Yeah, exactly.
They go on to run and then...
Well, that happens. So we see that a lot. So like I said, we've been doing PrEP for ages now, and certainly it's really... We're doing a lot of work within the PrEPX study looking, because we're collecting data on condom use longitudinally every 3 months in PrEPX. And we're currently doing a study looking at what are the behaviour changes over that time. In Vic PrEP, which is the sort of baby PrEPX that we ran in 2014, 2015, there was no reduction in condom use at the start until the 9-month mark. So at 9 months, people started dropping off condom use, which kind of makes sense because at the start of Vic PrEP, because this is 2014, which doesn't seem like a long time ago, but in the PrEP lifetime, it's a lifetime. At the start of Vic PrEP, people probably didn't have much faith in the effectiveness of PrEP. Whereas by the time the 9-month mark came around, there was lots of data coming out saying PrEP is effective. So I think risk compensation is a normal thing. People risk compensate in all aspects of life, and I think it's only normal that you're going to see that when you reduce someone's HIV risk with PrEP, that they're going to use less of other risk reduction strategies.
So if, as a GP, if a patient were to come in who's low risk, 100% condom use, asking for PrEP, would you try to discourage them out of PrEP? Or?
No, I would have a talk with them about why they want to go on PrEP, what their motivation for going on it is. I was going to talk about that tomorrow, and probably still will. I've had quite a few guys come to me who are a little bit older, and they lived through the sort of 80s and 90s and have a lot of HIV fear, and that HIV fear has wreaked havoc on their ability to find partners and form relationships, and they really just want to go on PrEP because they want to feel like they can meet people and not be at risk of HIV and not have that HIV fear constantly at the back of their mind.
Thank you.
Yeah, I'm happy for them to go on PrEP, it's fine.
Just a reminder as well that that person you're talking about technically wouldn't be eligible to get funded PrEP.
Oh, yes.
In New
You
Zealand.
don't have a self-importation scheme here, do you?
Yeah, you can. They can still import it.
self-import.
No, they can still import it.
Once they stop using condoms.
When you stop using condoms.
This is being recorded,
Right, so we had a few questions come in. One of them I think you answered, Nikki, which was how do we find a list of the local specialists who will be prescribing it? So was that through...
Sorry, I'll just answer that because there's a list of GPs that the New Zealand AIDS Foundation keeps who are interested in prescribing PrEP. But in terms of local specialists in Auckland, the best thing to do is to make a referral, an electronic referral to the Sexual Health Service. In other parts of the country, everybody else will have a different. Christchurch is the same, so there will be like a virtual consultation that occurs.
There will be DHBs where this pattern does not exist because there is no locally named specialist. So I invite the community actually and the GPs of those towns to start a revolution, agitate and instigate with their DHB to work out a pattern which might involve the smaller DHBs forking out some money to pay the bigger DHBs a fraction of their specialist FTEs.
Developing that relationship.
So let's say someone in New Plymouth who wants to go on PrEP and needs PrEP and their GP has got no local specialist to refer to, really, that's where I would like to see more community involvement, agitating for all the DHBs to work out what's going to be the referral pathway.
The other question was, can you access the ASHA guidelines or this pathway online? Which I think we can, yeah.
The link's right there.
Yep, there you go. There was a question saying, are there any pharmaceutical developments of similar medications that may be only taken monthly or annually in any form?
There are. So I forgot the name of the trial now, but there's a trial looking at cabotegravir and cabotegravir rilpivirine injections. There's cabotegravir. No, cabotegravir.
I think it's cabotegravir alone. And I can't remember the name of the trial.
No. But there are. So there's injections, and it looks like they were hoping for 3 monthly injections, but that doesn't seem to be quite effective enough. So now they're talking about possibly 2 monthly injections. So I think that's very exciting, because that obviously, particularly for some people who, I don't want to label anyone, but there are some, this is me just going on. People who are particularly high risk of HIV, unfortunately, share some characteristics which tend to make them chaotic somewhat. Can you say that?
Train wrecks.
Sorry?
Train wrecks.
No. It makes it difficult for them to adhere to daily medication use. There you go. So having the option of an injection every month or every 2 months would be perfect for people who might not be able to take medication every day and might particularly need it.
Also, having a nucleotide-free PrEP probably will overcome some of the toxicities, particularly metabolic toxicities, so if we had other classes of medications to be used.
I still worry that PrEP gives people wrinkles, but it should be terrible.
Linking on probably to that was a question about why you think there was no linkage between the increased risk and PrEP adherence in transgender populations.
Well, I think the transgender populations in the United States are very different from in Australia and New Zealand. I don't think we see the same disparities here, or I presume not here either, or in Australia compared to the United States. So I think they face a lot more discrimination in the United States. Access to healthcare is a lot more difficult. People are often unemployed because people won't employ them because of discrimination, and they end up in sex work, and even to the point where, and there's been studies on this, to the point where a transgender woman who is engaged in sex work gets paid less per act of sex than a cisgender woman. And hence she needs to see more clients in a night in order to be able to pay the bills. So it's a very complex environment, and I don't think we've really worked out why their adherence is lower, but I imagine that if you're busy having sex with lots of guys just so you can pay the bills, then taking a pill every day may not be a priority.
With regards to the eligibility criteria, do we assume if they use methamphetamine, they will engage in high-risk behaviours?
Well, it's been epidemiologically linked with high-risk behaviour. That's what we know. We don't assume, but we know that methamphetamine use for sex is linked in a statistically significant way to high-risk behaviour.
And the last one I have on here is, where do prescribing nurse practitioners fit into this in New Zealand? Is it with follow-up and repeat prescriptions, or where?
I would say so. I think actually the special criteria says any relevant health practitioner, which by definition includes other than doctors. Yeah.
And we use nurse practitioners in Melbourne very successfully. I think it's a great model.
Are there any other questions from the floor?
I haven't looked at the latest guidelines that have been put up. I was just wondering about the tail-off period of 28 days, which in the UK, of course, they've got a lot shorter. It's a lot shorter than 28 days. which would be, quite useful because some people go on sex parties and then they're going to come back and 28, and that's the only time they're actually using PrEP, when they go away and they come back to.
Like I said, there was much back and forth about this, and particularly this discrepancy between the tail off and the Ipecac dosing strategy. And I think it's interesting, in the UK, I was there when they launched the impact trial at Dean Street, because it was just before the EACTS conference in Milan. And a lot of their guys are going on to intermittent PrEP as part of the impact. So the impact trial is about 10,000 people going on to PrEP across England. So not just London, but right across all the sexual health clinics in England. And a significant proportion, I think, it might even be half, are choosing to go on to intermittent PrEP. So they've embraced intermittent PrEP a lot more than we have down here. So maybe we're a bit more cautious. So obviously the cautious thing to do is to say, continue for 28 days. I would think it's fair to say that the first week is the most important. But I hesitate to contradict the guidelines.
What about women that go on PrEP? What do the last version of the guidelines say? So how many days before you need to start PrEP if you're a woman? 7 days?
Yeah.
Okay.
Yeah.
Is that a change?
I think that was in the previous version as well.
Okay. Used to be a bit longer to achieve cervical-vaginal protection.
Yeah, I'm pretty sure. I can check again. But
We have a further online question, which is it's a case study. What concerns are there about a patient who's greater than 40 years old, has a history of hypertension on medication, metoprolol, and is currently normotensive with an EGFR greater than 60?
Well, this is a case for tomorrow. But
There you go.
So I guess the important thing is to do a full cardiovascular risk assessment, because obviously the cardiovascular risk is linked to renal risk, and do a urine protein creatinine ratio, urine phosphate, the whole works, just to make sure you've got a good hang of their renal health. If the hypertension is well controlled, then that shouldn't be an impediment to going on to PrEP. But I think it'd be wise to have a bit more closely follow up. So get them back in a month and just check, where everything's at, where's their blood pressure at, where's their kidney function at, rather than get them back in 3 months and find that there's been a problem for a while.
I guess we haven't explicitly said that tonight, but essentially PrEP is not a prescription. There you go, see you in a year.
No.
It's basically subscribing to a comprehensive general health, really, and sexual health program with monitoring every 3 months, and non-adherence to the program precludes essentially the possibility of having repeat prescriptions.
Yeah, I think exactly. The safest way to do PrEP is to subscribe to the whole program, and that includes vaccinations and general health care and mental health care and the whole kit and caboodle.
I can yell. Can you all hear me?
Clearly.
Yes. Yeah. My question is just, do we know that
Can you just use the microphone so everybody...
Oh, yeah, of course. Sorry.
We've got about 100 people online listening as well.
Hello, people at home. My question is, do we have an idea of the number of people that are eligible, that would meet the criteria for PrEP in New Zealand?
In New Zealand?
Yeah.
Well, we piggybacked on the mathematical modeling done by the Australians, and then taking into account that our population is smaller, I think we figured out in some way that there will be probably around 700 very high-risk men.
Well, in Farmax's decision, they've said around 4,000.
4,000.
We're reviewing
Okay.
that based on the current criteria.
Cool, thank you.
So where do they get the 700 from?
It's all this modelling. Who
Yeah,
knows?
exactly. But I think the whole point will be, if we target PrEP to the high-risk men, we might have a very significant impact down the line, even with relatively small numbers, something that you guys have already seen. Can you tell us about the preliminary impact that PrEP is having on the epidemics in Australia?
Yeah, so the EPIC trial in New South Wales and the PrEPX trial in Victoria targeted particularly, in quotation marks, with people at high risk MSM. So the explicit aims of PrEP-X were to, well, the sample size calculation came to about 2,600 people. 2,600 high-risk MSM would need to be started on PrEP in order to achieve a 30% reduction in HIV incidence amongst men who have sex with men, and that would translate to a 25% reduction in HIV incidence across Victoria, given that HIV is mainly concentrated amongst men who have sex with men in Victoria. There's a bit of a lag in reporting data, as there always is, but certainly the data, I can't remember the exact data from EPIC in New South Wales, but they've shown a significant drop in new HIV diagnoses.
I think you have achieved a third reduction.
In EPIC,
it?
yeah. So whereas the Victorian data has a bit more of a lag, but so we haven't got that final data yet.
So hopefully in New Zealand, from 220 new HIV infections per year, we can reasonably expect to drop to 100, 150 if we target PrEP to the right high-risk men.
But that doesn't mean that anyone else shouldn't be able to start PrEP. Just, getting on my soapbox again.
No, but as a country, if we want to prioritize our funds to achieve the maximum public health result, we should really start, as we did, by prioritizing the very high-risk men, and then maybe in a year, when we review the special authority criteria, widen the access if we can afford it.
And this is my ignorance of the New Zealand health system, but in the clinics, you said there is personal importation scheme, so can New Zealand practitioners assist people to import PrEP themselves?
Yes.
If they don't meet the criteria?
Yes, yes, yeah.
This is a funding question, but our patients all say they are at risk of having condomless anal sex within the next 3 months, so they know the criteria, and they're not going to exclude people who want to take PrEP.
This is a problem with criteria, eligibility criteria, which is why in PrEP-X we didn't insist on people meeting the eligibility criteria. We said, well, because if you do, then people will just tell you that they meet the eligibility criteria.
And there's
nothing to be done about
that,
it.
But,
We just have to accept what people tell us.
Yeah, exactly.
And if they've been coached on what to say, then...
Having, just as a bit of information, I guess, the price of PrEP online from the pharmacy. So before the PrEP-X trial started, we were assisting people to self-import PrEP in Melbourne. And the price of PrEP has now dropped to $20 a month, including postage. That's Green, well, should I say? Green Cross Pharmacy.
So provocatively, I would say if your patient is an MSM that doesn't meet the funding criteria, but is responsible and altruistic, should actually put their hands up and say, I can afford, I will pay and import PrEP and leave the funds available for the guys who are higher risk than me and cannot afford to self-import PrEP.
But it's interesting. So, I mean, I'm a bit of a social media fanatic. There's been a lot of discussion online since PrEP came on the PBS in Australia. There's been a lot of discussion in these forums. And there's quite a few guys who have actually said, I'm not going to get a PBS script for PrEP because I don't think it's morally right for me to get a PBS script. I can afford it. And I don't think... So the Australian government pays, I think, about $200 a month to the pharmaceutical companies who make PrEP, and the patient pays about $37. So it's cheaper to import, $20 a month, but there's quite a bit of discussion and guys saying, I just don't think I should get a PBS script, I'm going to keep self-importing so that the government doesn't have to spend this money on me.
Oh, sorry, someone just...
Just on the self-importation thing, I kind of have a problem with that ethically in that the drugs are coming in from Swaziland, which is one of the highest prevalence HIV countries in the world, which has highly subsidized medication for treatment of people for prevention of transmission, and that's being resold back out to gay white guys for prevention. So I think it kind of, and that I feel personally that it could jeopardize the subsidy of those drugs in that country feel like that's my problem.
Yeah.
I think it's better if people actually go through their own channels rather than trying to draw drugs out of Swaziland.
Yeah, I think it's a fair point, and I think it might. I don't know. It's an evolving space, and it's kind of it used to be $120 a month to get PrEP online, or even more. I think it was $150 or something. And I think at that price, you could argue that you're actually sponsoring the manufacture of antivirals in Africa. But now that it's dropped to $20 a month, you probably can't make that argument. So I think I'm certainly not saying that people should import or shouldn't import, but I think it's a very interesting space at the moment.
So I just wanted to ask about the quality assurance of product that is imported.
So Dean Street or Chelsea Westminster did a study last year on imported PrEP, because PrEP wasn't, and still isn't, on the NHS. It's just available through trials, and the trials was just the Proud trial, which is only a bit over 100 guys. So lots of people were importing, and they did an audit of the quality of the medication that was coming in, and it was dinky dye. What's the equivalent in New Zealand?
Good as gold.
But that was when they were doing it. Obviously, that doesn't mean that this will be the case eternally and forever.
The major manufacturers of generics are constantly tested and monitored by WHO, because basically WHO buys the generics for the treatment of HIV in developing countries. So they are the big Indian I don't want to say the names, but the big Indian manufacturers of generics are perfectly safe.
Would you be able to go over the indeterminate HIV tests during PrEP, please?
Yeah. All right, let's come up with a scenario. Do you have a scenario in mind?
No, I just had a question from the audience at home on the last thing, and then we'll go on to that one.
Okay.
Basically asking which websites to get PrEP from. So we normally say to people to go to the Green Cross website, and basically that's what I was going to say.
Yeah, I don't want to name any particular pharmacies, but there's a grassroots community organisation in Australia called PrEP Access Now, who are quite happy to facilitate access.
Well, the reason why we recommend Green Cross pharmacies in New Zealand is because New Zealand AIDS Foundation made a deal with them, so they were making available a coupon for free PrEP every 10 they sold.
Okay.
So there was also, again, this altruistical space of paying for PrEP and allowing someone else who cannot afford it to get it for free.
The question was indeterminate test results during PrEP use. Massimo, let's have a chat about this. So you've got someone on PrEP who's coming to see you in is it Rotorua?
No, Tauranga.
Okay.
Well, could be Rotorua as well, because I'm doing infectious disease clinics there as well.
Okay. They're a bit lost, but they figured out you're at Rotorua as well.
Okay.
And they're coming to see you there. And you've been seeing them for about a year now, and things have been going well, and you get an indeterminate test result back for this person.
Mm-hmm.
So they've got let's say they've got a positive antigen antibody ELISA, and do you do Western blotting here, or do you use RNA?
We can have both. Yeah.
Let's go with Western blot, because you get an indeterminate RNA. And they get a group 3 Western blot. What do you do?
Well, pretty much that sounds like the sexual health exit exam, clinical scenarios. So first of all, history.
Yes.
So you want to
I'm
know
your patient.
Exactly. So I want to know what's been happening in your sex life over the last 3 months. The number of partners.
I can't thank you enough for these pills. It's been fantastic.
You're welcome.
Thank you, Maso. You're a lifesaver.
You're welcome. With how many sexual contacts have you had condom-less receptive anal intercourse in the last 3 months? Yes. So can you give me a number? 5, 10, 20?
It's a bit hard to say because I went to a sex party the other night and it was a bit dark, but let's say 50.
Let's say 50 in the last 3 months, okay. And have you been well, or have you had any symptoms whatsoever?
Well, I have been feeling a bit tired over the last couple of weeks, but you know, it has been quite busy, and I've been using a bit more meth than previously, so I don't know, it could just be that.
So you cannot really tell me anything more specific about fevers or night sweats
Yeah,
or losing weight?
I had some sweats the other night as well. I haven't, maybe I've lost a bit of weight, but then I haven't had much time to eat. So.
Okay. Yeah. So after history, you pass to the clinical examination, physical examination. So I'm going to examine you, and what am I going to find?
I thought you'd never ask.
You can tell me the findings. We're not going to do the proper examination here.
Come to New Zealand and I don't even... so I've got what have I got? I haven't really got much. I maybe got a little bit of a faint motley rash, but not much else.
Okay. Have you got a thrush in your mouth? Have you got thrush
no, I don't have
in your
thrush
mouth?
No.
Lymphadenopathies?
No, not really.
Swollen glands?
No.
And a rash, a maculopapular rash?
Yeah, a bit sort of.
Is the rash on the soles and on the palms of your hands as
a
well?
little bit.
Yeah. Okay. Good. So I guess we need to take some more tests here, including a full STI screening, urines, rectal swab, throat swab. We'll repeat some bloods, and I'm really keen to repeat a syphilis test. I know you have tested positive before, but since the last time we have treated you,
because that's what I thought. Like this rash looked a bit like
could be
last time.
Could be, absolutely. So after the last time we treated you, your RPR came down quite nicely. But if now it's going up, it might be syphilis reinfection. But there was also the HIV test that was not completely clear as it normally was. So I'd like to repeat that. It's now like 1 week, 2 weeks since we took the first sets of, the first set of blood. And I will also ask for an HIV RNA because, people on PrEP sometimes can have some funny tests during.
Oh, fair enough. It sounds like you know what you're doing. Do I? Should I keep going with my PrEP?
That's a very good question. I would like to see you at a very short
I'd like to see
turn. Yeah, so I would like to see you next week when we've got all the tests back, so we can decide what to do with your PrEP.
That's a date. Let's do that. I guess there's a couple of options in this.
You're coming out of the role, yeah?
I'm a method actor. I guess because we think there's no straightforward answers to that scenario, obviously. I guess one of the things that we've been thinking about a lot is when you're faced with this scenario of some uncertainty, do you add a third agent? And there's pros and cons for doing that. Obviously, adding a third agent would be switching someone straight to HIV treatment on the presumption that they may be seroconverting, which possibly is a good thing because it possibly, the risk with continuing PrEP is that you might induce resistance. So your three options are you stop the PrEP and don't have sex. But the difficulty is if you're dealing with someone who's had lots of high risk recently and you stop the PrEP and tell them to not have sex, the chance of them not having sex, may not be that great. So if they're not already seroconverting, it may cause them to get HIV. You continue to PrEP as is and risk antiviral resistance, or you add a third agent and switch, so you switch them to treatment whilst you're waiting for your other tests. The problem is how are you going to pay for that, because they don't have HIV technically. And the other problem is...
Could be a functional monotherapy in the worst case scenario.
Well, possibly. So if they've already got TDF-FTC resistance, which wouldn't be very likely, but it's possible, and then you're adding a third agent, they're possibly going on monotherapy. If you're going to add a third agent, I wouldn't use raltegravir. We've been using dolutegravir just because of the higher barrier to resistance. And there's, I think you can be fairly confident if someone, even if they had an M184V, so even if they had emtricitabine resistance, they probably would be fine with Truvada dolutegravir, and you wouldn't get resistance to the dolutegravir. But yeah, like I said, there's no right or
I guess the reason why I said, okay, continue PrEP for a week, it's because you had possibly an alternative diagnosis,
Yeah.
syphilis.
And you're probably not going to do much harm in the week of PrEP.
And in a week, it's very unlikely we will select for any more resistance
Exactly.
mutations. But definitely, I will not be happy for someone in that situation to continue with PrEP for 3 months, let's say. Absolutely.
And this guy
not.
wants to see you again anyway, so that's
Yeah.
fine. No, but
I'm going to call time in a minute, unless you've got anything really important you want to say to finish off.
really important.
I do have more questions online. Well, we're 20 past, we're due to what we've finished up, so we probably...
I really don't mind.
If you have a short question, we can...
There's a couple of... There is, with full adherence on PrEP, should we counsel that there is a chance they could still be unlucky and acquire a multi-drug resistant strain, in which case PrEP would be ineffective?
Well, this comes down to consent in general, doesn't it? I mean, do you also counsel them that they might get hit by a bus when they walk out of your clinic? I don't know. I mean, it all comes down to, you know, how big is the risk and is that risk relevant for that particular patient? And I don't think you can give sort of a blanket statement on it. I think we do advise people that PrEP is not quite 100% protective. It's certainly the most effective HIV prevention strategy that we have, but it's not 100%. And we do advise people to try to continue using condoms, partly because of that, but really more to reduce their risk of other STIs.
Okay. And the last one may not be quick, so you feel free to pass on it, but it is, how do you defend such negative anti-gay comments in social media? For example, why should my taxes pay for these gay men to have unprotected
There's
sex?
a very quick question to that, because when Pharmac did the consultation, they had someone asking exactly that, so why should we pay for someone who puts themselves at risk? And Pharmac answer was brilliant, and was Pharmac does not consider the cause of diseases when deciding funding or not. And basically my add-on to that is, if we start allocating funding on merit, we get on a very slippery slope. So why do we treat smokers? Why do we treat alcoholics? Why do we treat obese people? Why do we treat sedentary people? You know, who is without sin can raise their hand, as that guy said 2,000 years ago. So we all have something that we will not be entitled to receive treatment for because we have been misbehaving. So why that shouldn't apply to sex as well?
Exactly, and I think the other thing to keep in mind is that we've been hammering the condom message for decades now, and despite that we've seen increasing year-on-year increases in HIV diagnoses. So whatever we've been doing hasn't been working, so we need to do something else, and this is the something else.
Great answer, thank you both of you. Fantastic. So is May around? It has on the program she's going to wind things up, but I'm winding things up? Okay. All right. So just before we finish, I want to mention that there are a couple of resources that are going to be on the Goodfellow website, along with the webinar. Mike Pohl has very generously provided these. These are his little forms that he's made up for his patients who come to his practice. He's got a form for them to fill out in reception about their risks and whether they're seeking a consultation about PrEP. And he's also got a nice little template for tests and when to do them. So those will be available. And of course, you've all got the guidelines from ASHM around what your testing protocols should be as well. I'd like to thank all of you for coming tonight, and everybody out there who's watching from somewhere else. I hope you found it useful. Thanks very much to Massimo and Vincent for wonderful presentations. And I hope some of you are coming to the full day HIV update tomorrow. If you are, we look forward to seeing you there. Thank you.